our original recruitment sample, we had people from the age of 18, actually 17. There were 3 individuals who crept in who shouldn't have been in the study. It was against our protocol, but I guess there was some, they didn't tell us their age correctly, they were actually 17, but from 18 to 96 years of age. The data collection followed protocols in many of the international studies. We asked for informed consent for long-term follow-up. We also, I should mention, asked informed consent for data linkage. Most of our participants have agreed that their data can be linked with other data in government databases. So we can link that data in, that's potentially something we can do. We had interviews and examinations by doctors and nurses. We collected biosamples, particularly blood and urine. We also collected buffer code for potential genetic research. The Ministry of Health, through the Medical Research Institute, also did a sub-study where I think more than 1,000 participants collected their urine for 24 hours, and that's to support the National Sodium Intake Study. And I should mention one other thing. The study was supported by a computer-assisted personal interview system, a TAPI system running on computer tablets, which was developed here in Sri Lanka. That was our first wave. With COVID, we couldn't do fieldwork in recent years, but partly in response to the COVID crisis, we launched a second wave by phone, and that's using computer-assisted telephonic interview, or CATI. And that second wave was completed between August 21 and August 22, and we've now extended it because of the ongoing crisis to track the impact of the crisis on the population. Now that wave attempted to recontact people in the original cohort. We reached about 75% of them, and we supplemented them with a new group of respondents who were reached by randomly dialing phone numbers. Most of those people have also agreed to be re-interviewed in the future, although what we will do with them in the long run is not entirely clear at this point. A couple of things I will say about that. So our second wave has 2 samples, this randomly dialed sample and the original cohort who will be reached. There are some differences. If you do a phone survey and randomly call people in Sri Lanka, it's probably worth sharing. The samples in Sri Lanka will be very biased. They tend to be biased towards younger people, more urban people, and richer people. And I have here just a comparison of the income categories in our cohort that we could reach by phone versus the random dial sample. And you can see there's quite a difference. So one of the advantages of using a cohort to do a phone survey is that you can get much better representation of the population. At the same time, our phone survey was useful. It gave us additional data points, and it gave us people in the crucial 18 to 20-year-old age group, because nobody in the cohort is in that age group anymore. Just a rough overview of the timeline. So this is a timeline of the fieldwork, wave 1 and wave 2. And then we've extended wave 2 as wave 2X, wave 2 extended. That's still ongoing. I think interviews will be done today, and will happen every day essentially. And will continue as long as we can find money. And that's really to monitor the impact of the current economic crisis. And the kinds of things we collected, we collected data through interviews, that's in green. So we had some core modules covering social demographics, employment, retirement, NCD history, healthcare access and use and spending, and psychosocial factors. Then we had extra interview modules in the first wave covering particular disease screens and risk factors, and medicines use. And I think Dr. Sami will talk about that later. And then we had physical examination component, which covered anthropometrics, biochemical markers, and we did blood pressure measurements, ECGs, spirometry, and a whole host of other things on the participants. In wave 2, which was by phone, we kept the core question modules. We dropped the examination modules for obvious reasons. We couldn't examine people, but we had additional questions focused on essentially COVID-19 and the impact of the crisis, as well as asking questions about people's preferences and their views about public policy. So what have we collected so far? We've done, as of yesterday, almost 18,000 interviews with 9,000 unique respondents in both the random phone sample and the cohort. We have almost 50,000 samples biobanked across 3 university laboratories in the country, including buffer code available for genetic research for DNA extraction. And we do have consent in most cases for doing that. And we have several gigabytes of data, including, not in a position to share some of the communications we get. People were very happy to participate in the study. I mean, we put them through a lot. I mean, the participants had to collect their urine for 24 hours and they carry bottles around and do all that stuff. We took blood from them, we examined them physically. But most of them had a very good experience. They continue to write to us, and we've maintained that good rapport. Just one indication of that, in wave 2, when we phoned the ones we had phone numbers for, our refusal rate was about 1.7%. So 1.7% respondents refused to talk to us again. Pretty much everyone else who was still alive and could re-interview. They remain very happy in their participation in the project. We've done some work to figure out those 25% we can't reach by phone. We think we can still reach them through the electoral register. And so if we do field work in future, we're fairly confident we can reach 90% of our original goal.